So good morning and welcome to today's subcommittee on prevention for the SURG statewide substance use response working group. Let's go ahead and start today's meeting by proceeding with roll call.
All right, Senator Doñate.
Here.
Debbie Nadler.
Here.
Eric Schoen.
Present.
Jessica Johnson.
Present.
Senator Sievers-Gansert.
Here.
Mr. Chair, we have a quorum.
Thank you so much. Seeing that we have a quorum, we can go ahead and proceed with public comment. So at this time, I will go ahead and open public comment for folks on the Zoom meeting that would like to participate. As a reminder, public comment will be limited to 3 minutes each. And again, this is a moment that we can dedicate for folks if they have from anyone in the public that would like to make a suggestion or anything on the agenda items today. And of course, just wanted to recognize the fact that we do have time constraints. Let's go ahead and Emma, is there anyone on the line right now that would like to provide public comment?
Yes, I see Debbie Nadler and Valerie.
Ms. Nadler, please proceed.
Yes, hi there. Thank you. I've got a question and maybe it needs to be redefined, but our committee is supposed to be the prevention committee. Am I correct? And that, can somebody confirm that our subcommittee has to do with prevention?
Yes, ma'am.
Okay, so we have two other committees. Our two other committees are treatment and recovery is one, and the other being resources. I was not at last week's meeting, unfortunately, because I was doing an International Overdose Awareness Day event. I received the email on the minutes and everything for the meeting last week. And I must say, I was a little bit disappointed in seeing that somehow our prevention committee has turned more into treatment, resources, and recovery. Not that that's not important, it's very important, but we have two other committees focusing on that. Perhaps we need to define prevention. Is it preventing an overdose or is it preventing first use, which leads to that path? Until we focus on preventing the first use by our youth, then we are complicit in the millions of lives that will be lost because we are not using primary prevention. Just last week, Northern, I believe it was in Ely, Police Department confiscated 56 pounds of fentanyl. And just to break it down further, 56 pounds of fentanyl actually is equal, 1 pound kills 227,000. So the 56 pounds that were confiscated could have killed over 12 million people. We are spending a lot of money. The police department is doing their very best, the officials, everybody, in preventing drugs from coming in to our state. But we know with that many that they are catching, that there are more coming in. So how do we prevent these drugs from getting into the hands of our innocent youth? They don't know, the parents don't know. And it's up to our committee to make recommendations on prevention, preventing these kids. Just the other day, and it wasn't in our state, but it is happening in our state. Fourth graders died. Another state yesterday in LA, Hollywood High School, a student died in the bathroom at school. There is nothing that we are doing that is on primary prevention. We need to fight for this. None of the money is going towards prevention.
Ms. Nadler, I think you've reached your time limit for this. We'll come back, of course, as we're doing the discussions at a later agenda item, but I just wanted to let you know that.
Okay, I'm sorry about that. Thank you.
You're good. For the sake of public comment, I want to make sure that everyone else gets the opportunity as well. Let's go ahead and proceed. I see that Ms. Valerie Haskin has her hand up, so please proceed.
Thank you, Chair Donyate. I appreciate this opportunity. For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. I only had a chance to very quickly go through today's materials. I'm very sorry I'm triple booked, but I wanted to jump on and say that I'm so pleased that the prevention coalitions are here at the table. And I just wanted to reiterate that they are essentially, particularly in rural Nevada, the glue that holds a lot of these programs together. And so I really feel that when we're looking at places to house programs, really focusing on how the prevention coalitions can be utilized is the best strategy within a lot of these things. And with that, I think we also need to use these funds in a way that allows the prevention coalitions to use, of course, evidence-based and best practices, but also look at innovative strategies where we can work with program evaluators and others and take some of these strategies that maybe have been implemented in other communities that don't quite fit for Nevada or our communities, but see how we can alter them and then properly evaluate them and see how we can build something out that is meaningful and works for us. Beyond that, I think resiliency programming, when we're looking at prevention, resiliency is highly correlated with reduced use and reduce onset of substance misuse. And when we're talking about prevention, this is long-term, not just a webinar, not just a school assembly, but actual education that relates to self-awareness, self-regulation, mental agility, strengths of character and identifying those, learning how to connect with others, and also learning how to affect our thinking for learned optimism. This really should be we need to look at weaving in these things, strategies with the work of school social emotional learning programming, but also working with parents, because if kids aren't getting this at home, it makes it more difficult for them to build these skills. As we look at that sort of thing, really weaving together the coalitions, the schools, the Nevada Resilience Project, and other state offices to making sure that we're on the same page, but launching really some resilience type focused programming. And really, and another place there is that the coalitions have the capacity to do a lot of this long-term programming that the schools just don't have the capacity for, because there's already so much put on them. And last but not least, I wanted to mention that the board for whom I work, the Rural Regional Behavioral Health Policy Board, has BDR 361 this next legislative session. And the purpose of that bill is going to be to build out a behavioral health workforce development center to bolster our workforce and grow Nevada's workforce within Nevada. And that center will be working with partners from K-12 through professional practice. So if anybody would like to talk to me about that, I know I'm running out of time, so I'd be happy to. I'm just going to stick my email address in the chat if that's okay. If that violates OML, just let me know and I won't do so. Thank you very much, all, and I appreciate your time.
Thank you so much, Ms. Haskin. I believe Ms. Fairchild has a comment, so please proceed.
Rhonda Fairchild for the record. And I just wanted to reiterate what Debbie was saying, that I don't know how to say it. The prevention group should work on prevention, because treatment and recovery and resources are being covered in the other groups. And I've been trying to go to all the meetings. And so I think it's really important that we focus on that I think what I would like to hear as the public is more prevention strategies from this group for the young and for people who are already using. So I liked what Debbie said about, are we preventing them from using, or are we preventing them from dying? And I'm not sure I'm clear on that either. I'm not sure prevention just covers that whole spectrum. But I know that there are different ways to approach prevention of using and prevention of dying. So I want to make sure that I understand from this group that that's clear, that there's a clear understanding of that. So thank you for giving me some time.
Great, thank you so much. Emma, is there anyone else that would like to provide public comment at this time?
I do not see anybody.
All right, I will go ahead and close public comment, and this time we'll continue on with the next agenda item, which is to review and approve the minutes from the August 31st, 2022 Prevention Subcommittee meeting. Members, do we have any questions or comments on these minutes? Seeing none, I'll go ahead and entertain a motion at this time to go ahead and approve the minutes.
So moved. For the record, this is Eric Schoen.
Thank you, Eric. Do we have a second? And we have a second from Senator Ganser. Any discussion? All in favor, please say aye or raise your hand.
Aye.
Aye, there we go. I think it's unanimous. So the minutes are now approved. Thank you.
Just a note, Mr. Chairman, because Ms. Nadler was not at the last meeting, she can abstain if she chooses, or if she, I see her nodding, but she's on mute, so I'm not sure.
Ms. Nadler, would you like to change your vote to abstention, or are you okay with the motion for aye? Just to clarify for the record, it looks like you're on mute.
Thank you. My phone is acting up. Yeah, I abstain because I wasn't in there, but if at some point I can make comments for the public record, I'm not sure if what I spoke about beforehand is on public record, but I would like to comment on last week's meeting at some point, if at all possible. Thank you.
Well, when we get to the recommendations, that's when we'll discuss any concerns. But for right now, this is just pertaining to the copy of the minutes. So
thank you. Thank you.
Looks like everyone was in favor, and then please mark for the record as Ms. Nadler for her abstention. Okay, let's go ahead and continue on to the next agenda item, which is our presentation from the Nevada Prevention Coalition update. So we'll go ahead and proceed to Ms. Jamie Ross when she's ready.
Good morning. Thank you so much. And thank you so much, Emma, for getting all of this ready and doing all of the background work. We really appreciate it. And thank you so much to the members for the work that you all are doing. This is incredibly important work, and we're so excited to be working with you. My name is Jamie Ross, and I wear multiple hats, but today I'm wearing the hat of the coordinator for the Nevada Statewide Coalition Partnership, and I will pass it off to Hannah.
Good morning, everyone. I am Hannah McDonald. I am the Executive Director of Partnership Carson City. My coalition serves your wonderful capital.
Next slide, please, Emma. So we've been sitting in on multiple of the prevention subcommittee meetings, and these are the three things that bubbled to the top that I think the prevention coalitions can provide some insight to. How prevention coalitions grant funds within the structure that exists in the state of Nevada, some secondary, tertiary harm reduction prevention programs with policies to consider. We did see that harm reduction has been moved into this committee, and so we wanted to talk a little bit about some policies there. And then partnerships with prevention in schools. I know that Dana and Christy McGill spoke a few meetings ago, and we just had some additional context. There were some questions that you all had that the coalitions have a little bit of additional context for. So we'll just quickly cover those three topics. Next slide, please, Emma. Quickly, this is all of the prevention coalitions in Nevada. As you see, there is a coalition that covers every single county in Nevada, if not more than one. And if you'll notice, the longest existing coalition in Nevada was Partnership Carson City, which was incorporated in 1989. So there really are decades worth of information and community capacity within each of these coalitions. So just to cover that, so if anyone needs to reference back to see what community is served or their coalition serves, you can refer to this at any time. Next slide, please. And so we'll move right into prevention coalitions as grantors, and Hannah will cover that for us.
One of the wonderful things that we get to do as coalitions is provide grant funds to our other direct service agencies, youth serving organizations, law enforcement, and startup programs. And we like to think of ourselves as nonprofit incubators or program incubators. Next slide, Emma. So how the coalition structure began. Back in October 2nd of 2001, When SAPTA, but the Department of Public and Behavioral Health was previously called BETA, we worked with our bureau chief to go ahead and become formalized and take on different responsibilities. One of those main responsibilities was that because we mobilize our communities, we work directly with our direct service agencies, they come and sit at our table. It was decided at a state government level that the coalitions would be responsible for putting out the funds into our communities because we know our communities best. And we get to act as that middle person between the direct service agencies and our state government agencies as well. And with those dollars that we were able to keep in-house, we could fund many of our own programs as well. But for most of us coalitions, more than 85% of any dollars we receive go back to the community. So in November, Sheila Leslie, our Assemblywoman of District 27, and Carlos Brandsburg, our Administrative Mental Health Development Services, and many others who are listed there, you can go ahead and read through, all worked to find funding for multiple coalitions across the state. And we were able to ask questions and create a commitment for our coalitions to communicate with those key stakeholders and create a longevity of this process for the future. And as you can see, since 1989 until now, we've really grown and created a strong relationship within all of the 17 counties in Nevada. Next slide, Emma. So as grantors, we secure funding for our local agencies from city, state, and federal government agencies, as well as settlement dollars. And many of those settlement dollars we receive do come through the Attorney General's office, and that's a wonderful department to work with as well. We also subgrant or we contract to local partners. When we contract, most of the time it's with law enforcement or large media companies who can help us push campaigns across the state. And when we're looking at subgrants, we will do subgrants with Boys and Girls Club, our family resource centers, any other youth serving organizations such as mentor programs, or even our local schools and school districts. And we provide opportunities as well through donations and administrative fees. Some of the innovative products that come or programs that come through donations are dental programs for youth, paying for different opportunities such as them to go to summer camps and prevention-based activities that are not offered in other locations in their communities. One of the ones that my community or my partnership has is that we have the Youth Educational Enrichment Fund. We're able to pay for students who are unable to pay on their own for their athletics, their band practices, their karate classes, so they can be actively engaged in their community and have alternative activities. There's mini grants for our school social workers and our educators so that they can provide prevention programming throughout the summer or after school, and it's not coming out of their pocket. As we know, they already give so much. I already mentioned that youth dental program, but one of the great things that we love to do is keep our community educated, and we cannot educate our community if those who are providing services aren't educated as well. So we will fund opportunities for our teachers, our law enforcement, other department staff to get educated and attend great conferences or even host those ourselves. Next slide, Emma. Right. Is this you, Jamie, or still me? Still me? All right. The grant process. So we have multiple grants that have state fiscal years, the July to June, and we have others that are federal fiscal years, October to September. What happens is we apply for those funds. Once the funds are received, we then put those dollars out for bid into our communities. Community-based organizations can apply for those dollars, and then they are awarded those dollars should their program meet the requirements of the grant dollars. So applications are submitted. We do an internal process of reviewing, and we have great people that come to the table, review the programs, ensure that there's no duplication of programs being put out, that the program and the staff who are applying for it are competent in being able to provide that into our community. And that's a big one. We really want to make sure that when we're funding our community, the people who are going to apply this know what they're doing and we follow fidelity. we do, then we go ahead and we fund those awards, and they receive those dollars based on reimbursement, and we track and monitor those dollars the same way any other agency would receive grant funds. Next one, Emma. All right. I know this was great that this came out up in public comment, secondary and tertiary programming, and so I can cover a little bit of that with you as well today. All right, next slide. Thank you. One of the largest growing programs that we have across the state right now, which is borderlines on prevention and treatment, are our FAST and our MOST programs. So FAST was a very odd acronym, Forensic Assessment Services Triage Teams, and then MOST is our Mobile Outreach Safety Teams, provide services to individuals who are currently in a crisis situation, a substance abuse situation, and they receive assistance at point in time. FAST is a program that works within the jails to help individuals who are incarcerated as a result of behavioral health or substance abuse misuse, as well as having some coupled other diagnoses. And they receive treatment, they'll receive a case plan, they might receive drug court, but it is to prevent recidivism back into our jail systems. Our mobile outreach safety teams go on crisis calls with a clinical social worker and law enforcement. They go on a variety of different calls and respond to all types of crises. Yesterday, they respond to a homicidal suicidal situation, but this morning they responded to an individual who has dementia and was lost and trying to find her way home. So the cases are wide and vary amongst our MOST programming. There is some overlap with the MOST and FAST team, as an individual who may call MOST for assistance might also be a FAST client. So it is case management, not treatment, but they are provided a route to treatment should they need it. Once treatment is engaged, our hands are off of the programming. And these programs are really important because there are not a whole lot of other funding for some of these programs. And we save our counties a lot of dollars by helping people not end up back into the judicial system and get the access to treatment and care that they need. And it is an evidence-based program, which is a huge plus. Next slide, Emma.
And I will jump back in here again to focus a little bit back onto the harm reduction section. And I know that this has been covered in other subcommittees, but I did want to chat a little bit about that here. One of the most important parts of harm reduction is building community capacity, and that's an area where our coalitions can really thrive. There was a SAMHSA harm reduction grant, for many of you may have seen that on the news, and all of the coalitions statewide, as well as the harm reduction agencies within the state, co-applied for that SAMHSA harm reduction grant. Unfortunately, that funding was not received, but really focusing on the convening the partners, the building capacity, and most importantly, meeting the community where they're at, because what harm reduction looks like in urban Clark County is going to be very different than what harm reduction looks like in Elko or Lander County. But harm reduction is happening in every single county, and how can we help build capacity? And that's something that coalitions have been doing for 30 plus years. Next slide, please. And this is just additional information on some of the prevention programming in schools, how Senate Bill 69 influenced all of this information. So next slide, please. So the recommendation for prevention specialists in schools is one of the things that we know is our schools are the most important place where our kiddos get educated. But if we ask our teachers to do anything else, they are absolutely at capacity. So every coalition in Nevada has a relationship with their school district and can provide prevention specialists. So folks who are certified in best practices in prevention, who understand the strategic prevention framework and the multi-tiered systems of support and the positive behavioral interventional support and all of the acronyms that really focus on how can we educate our young folks, give them the tools in their toolbox, support them, be part of the screening teams within the schools, and not put additional burden on our schools directly, but encourage our communities to come in and wrap around our schools, whether that is funding prevention specialists in schools or prevention specialists in after-school programming, working with our community partners. And really what this does is it expands the prevention capacity within our state. And also incorporates the amazing work that our community health workers are already doing, oftentimes in schools. The community health worker program has really been incubated through the coalition structure. And the CHW program has really grown into this incredibly robust program throughout our state. And we want to ensure and model that moving forward. Next slide, please. Thank you. So Senate Bill 69, many of you know, did many things. One of the pieces of the Senate Bill 69, and this is in the 2021 legislative session, it provided a list of evidence-based programs currently utilized in schools. And so how that worked is the Department of Education reached out to the coalition and the school districts to compile everything that was currently happening in schools, and almost all of that was happening through coalitions, whether that was funded, the school districts were funded directly, or the programs were actually implemented by coalition staff who have longstanding relationships with schools and actually do the evidence-based life skills, positive action, Too Good for Drugs programs within the schools, and then continuing to collaborate with the Department of Education on evidence-based programs to create a website, to create a resource for our education professionals. As we know, they are absolutely professionals and experts in the field in working with youth, but may not be experts in prevention of substance misuse. So giving them additional tools and connecting them to the resources in their community that they may or may not know about. And I believe, next slide, please. Thank you. And that is, we've covered everything. This is Hannah's and my information. Please feel free to reach out if you'd like to chat with either of us, and we are happy to answer any questions you have.
Thank you so much, Ms. Ross and Ms. McDonald. Let's go ahead and have questions from committee members. I see Ms. Nadler has a question, so please proceed. Debbie, it looks like you're unmuting yourself. Please proceed.
Sorry. Thank you so much for that presentation. Again, I will say, Debbie Nadler, for the record, there is no focus on primary prevention in our schools. I called the CCSD yesterday and talked to the health services department, and the only thing that they have in the schools is something called Hazel Health, and that's an online service for students to use after school, parents to use. It's not really focused on getting our children to not use in the first place. I appreciate the fact that some of the coalitions are going into the schools. It's not enough. It's not stopping them from using. And I believe, if I'm not mistaken, Senator Heidi Gansert made a recommendation to our committee to put funding aside for the grassroots movements here in our state to do this. This is, I know there's many grieving family members and those in recovery as well. And that is our focus, is in going into the schools and actually speaking with the children. That we have got to focus on primary prevention. Secondary is great, but that's after the fact. You talked about how it will save money in our schools, but what will really save money in our state is if we stop them from using in the first place. I mean, it's.
Yeah, and Debbie, we can come back to that when we talk about the recommendations, but I'd like to be respectful of the folks who just presented. So if you have questions specifically for them on their presentation, I could take it right now. Otherwise, we'll continue.
Okay, well,
We'll come back to it.
are they responsible? Are they did this coalition, the committee that just spoke, are they the ones who put Hazel Health into the school districts?
No, that's a partnership between the company themselves and the school district.
Okay.
Yeah, so that's a separate digital health company that is doing work and they don't just do mental health, they do other.
Okay.
In general, yeah.
Okay.
And Debbie, I'm happy to connect you with the folks within CCSD. There is actually quite a bit of primary prevention programming happening within schools within CCSD. There's about 25 middle schools that are getting a semester-long evidence-based prevention program called All Stars, not to be confused with after school All Stars. They're entirely separate programs. There's multiple programs in elementary schools, from life skills to positive action to multiple programs that focus on multi-tiered systems of support and positive behavioral interventional supports. And so there is actually quite a bit of programming. And I think most folks within our school district would know the names of those programs, but may not connect that with substance misuse, because when people think substance misuse, they think DARE, they think, someone coming in and scaring kids straight about drugs, which we know isn't an evidence-based program. So it's connecting those dots, because what makes students successful in school is oftentimes the same things that what makes them not use substances and not do a multitude of risky behaviors. So I'm happy to connect you with that. And I say primary prevention is where my heart is as well. So I'm happy to support all primary prevention work, but also work closely with our community partners who do a multitude of the other important work in this community. Thank you.
No, I appreciate that, because I've had teachers call me from schools that my kids attended, and they told me they're catching their students using in the bathroom. And this is in middle schools. Mm-hmm. So I asked them if there's a program in place, and they have told me no. And now this is Southwest. I don't know what's happening all over our state, but I'm sorry, I cannot sit back. I have a grandchild who's going into 3rd grade, and he has already been offered drugs. And we need to open our eyes. I mean, you can Google it to see how many kids are being offered drugs, using drugs. They look like candy.
Right.
And
Ms. Nadler, I can, at the end of this meeting, I have actually had, actually for all the committee members, I have had conversations with NDE, the Department of Education, on curriculum standards and what gets taught at different various age levels. So I can forward that on as well.
That'd be great.
As supplemental
Thank
material. And that's separate from the community grants that we've discussed during this presentation. Ms. Ross, by top of mind, do you know how much funding you're getting right now for the grants in total, or what the amount of pot of money that you're handing out would be?
I do not have that off the top of my head, but I can by the end of the week get that for and I think what might also be useful is the total pot of money for prevention that all the coalitions receive, plus the percentage that goes directly into the community, because like Hannah said, about 85% of the funding that we receive goes directly to the community. And we can get that for you. I'll send that to Emma, I think, and get that out if that's okay. Oh, sorry, Jamie Ross for the record.
Thank you so much. And can we go back to the slide of the review?
Yeah, I'm so sorry. I'm so sorry. I do have one more question. Jamie, you're the person that I needed to ask this about. I found out that a bill was passed. I believe it's called AB 205 or SB 205, and it has to do with the schools at the end of the year reporting the number of times they've had to use Narcan naloxone. And it was a bill that passed in July of 2021. And I asked them, and they said that those numbers go to the DHHS, the Department of Behavioral Health. Do you have those reports?
Jamie Ross, for the record, I do not, but I can definitely connect you with the folks who do. Debbie, I think I've got your email, so I'll reach out directly to you after the fact, and we can chat offline. But yes, AB 205 is the Narcan in schools bill.
Okay, thank you.
If I may I add to that? For any of you up north, Partnership Carson City is our local distributor for Narcan, and we are the go-to trainer for Narcan as well. So should you have any need or desire to learn about it, pick it up, or stop by our office, you are more than welcome to. We are responsible for training all of the nurses in the schools and sports educators in the schools so that they know how to administer Narcan. It is kept on site, and I will be open and honest, to be fully transparent. The numbers are not shared with us, how often it has to be used, unless our law enforcement is letting us know. So when those numbers are reported to DHHS, they don't typically make their way back down to us unless we wait for some type of annual or quarterly report.
Thank you so much. Ms. Johnson.
Thank you, Chair Dunyate. Thank you, Jamie and Hannah, for a wonderful presentation. Really glad to have you both here today. I have a couple questions, but I'll prioritize them in the interest of time. I was grateful to hear about the work that was done on the Senate Bill 69 around evidence-based prevention programming and some of the partnerships that resulted from that. And I'm wondering what would be the next step on that bill for additional collaboration from your perspective? Where has that been a successful first step, and what would you say would be the next step?
Thank you, Hannah. Did you want to answer that, or did you want me to?
You go first.
Okay. So yes, it's been an amazing first step. The Department of Education, or NDE, thank you, Senator Dunyate. I have always called it DOE, but NDE has been a great community partner. Christy McGill has been a supporter of our community coalition since she ran Healthy Communities Coalition in her previous life. Really great supporters. And what we know is we cannot expect our education system to implement evidence-based prevention programming in every single school in the state without significant funding and significant community resources. So at this point, the providing resources and what the next steps with the NDE will be is to ensure that any school who does want evidence-based prevention programming goes directly to the coalitions as the community provider of that, and continuing to support that, and transparently to continue to find funding for that. These evidence-based prevention programming they're not free. They are oftentimes, they're always multiple classes, multiple sessions, many weeks, because what we know is a single program can educate, but they cannot change behavior. And if our goal is to change behavior long-term, we really need multiple sessions, and that's what our evidence-based programs do. So additional funding is our hope for the future. Hannah?
You know, Jamie, you really said what I was going to say. What it comes down to is a lack of funding. It's not that we don't apply. It's not that we don't want to put these programs into our schools and into our community-based youth serving organizations. But when there's only a 20% set aside for primary prevention, we can't do a lot. And so when we are looking to you, our leaders in the state, what it comes down to is a little more financial freedom to offer programs to our students. Because while primary prevention is cheaper than treatment, 20% is not enough. And we need more. But we also need allocated time in our classes. Because when we have a 6-week program and we have to go into a teacher's classroom and interrupt their class for 6 weeks, it is a nuisance. It is hard for them. They have their own goals and objectives that they have to meet. And while we know that longevity of life and health is to remain substance free, they also need an education. So we have to find some type of way to ensure that kids are getting a little bit of everything that they need. And whether that's substance abuse primary prevention in the schools becomes a mandatory class or a mandatory section of schooling. In Carson City, they receive about a 2-week education during their health classes freshman year of high school, and substances are never talked about again for the rest of school unless it is from us. We know freshmen are really impressionable, but so are seniors. So finding a workaround and finding more money.
Great, thank you so much. Ms. Johnson, did you have any other questions?
Yeah, a quick follow-up to that, if that would be all right, Chair. I'm curious, Jamie and Hannah, do you have offhand what a budget estimate to stand something like that up would look like? I imagine it would be quite the monumental investment. And I was wondering if you could also talk a little bit about the evaluation of these particular evidence-based primary prevention programs. So sort of a two-barrel question, double barrel, my apologies.
I'll go ahead and I'll jump in. I don't have a back of the napkin number for that, but I can definitely get you that information by the end of this week. I know that we have over 400 elementary schools in Nevada. We have many schools, so this is something that would be a big lift. So when you all see the number, don't freak out. We'll do a per school kind of breakdown. But yes, we can definitely come up with some back of the napkin numbers. The joy of working with evaluators and our evidence-based programs is they actually, any evidence-based program will require an evaluation. It will require a short-term evaluation, and all of the coalitions also do long-term evaluations as well. Whether that is, what we look at is statewide, the Youth Risk Behavior Survey, and what we are seeing is that the numbers for youth, we actually preliminarily, just earlier this week, got information from Dr. Kristen Clemens-Knowles, who implements the YRBS, that many substances are going down and have gone down. Unfortunately, there are some that are still going up, but that's really what we look at long term. And we actually all have independent evaluators or evaluators on staff who can evaluate the programs longitudinally. And I'll let Hannah talk a little bit more about what that looks like in detail.
So in Carson, we have 7 elementary schools, 2 middle schools, and 2 high schools, one of the high schools being an alternative high school. Currently, my office operates on a $2.17 million operating budget, but not all of that is primary prevention. As I mentioned before, we do secondary, and we have many other things that we do outside of substance abuse prevention. I think that's really important to look at when we're talking about how much money comes into our organizations. While our main focus is substance abuse primary prevention, we have a plethora of other things that we do. We teach ESL at our office, so that's part of my budget as well. To echo what Jamie said, we would really have to sit down and do a detailed budget of what does it look like to fund primary prevention in our schools, to have the staff, to have that opportunity to create a class that happens on campus. My guess is that we would need almost double what we have now. And just doing a quick budget for you really quick, looking at the numbers that I have for direct primary prevention in Carson City. We have about $500,000 that go to primary prevention. I would like to see at least $1 million, $1.5 million for Carson City alone. And that is looking at being able to touch every single grade K through 12, at least 6 weeks a year of their school year. Other programs are easier to fund, like suicide prevention. We teach that to every single grade 6 through 12, and it's a little bit cheaper to do because there's a lot of other players at the table, such as school social workers and stuff. But for Carson, I'd like to say about $1 million is what it would take. I hope that answered your question, Jessica.
Yes, thank you both.
Thank you so much. Any other questions from any of the committee members at this time? I don't see any, so let's go ahead and proceed to the next agenda item. Thank you so much for the presentation. Okay, so now we've reached and arrived to finalizing the subcommittee recommendations. Before I turn it over to Ms. Emma, I just want to make a quick clarification. So I just want to remind the committee members as we're doing this that, so today we've had a few discussions or a few comments, and I just want to be able to respond back to them. I always revert, whenever we talk about prevention in public health, I always revert back to the definition provided by the World Health Organization, which is we look at prevention from not just the individual level, but also the population-based level. And we can't just look at, because we're dealing with the nature of disease or public health, we also have to be mindful of early detection and, of course, treatment for folks who already suffer from the disease. So it's, I think there was a question of, well, do we prioritize folks not falling through the cracks, or what about helping the folks who are already suffering from this illness? It's both. And I think that's part of the, at least from the bill regulation, the prevention committee itself was tasked to look at the comprehensive subject of primary, secondary, and tertiary, which is the reason why we've set up the meeting so far to follow these footsteps. And I think that's going to guide us in our conversations today. So it's all of the above, not just one or the other. With that, let's go ahead and Ms. Emma, if you can go ahead and proceed with letting us know about the result of our prioritization.
Great. So prior to this meeting, we had our members reprioritize their top 5 recommendations, which I'm going to quickly go over before discussion and potential edits and votes on the 5 to 7 recommendations that this subcommittee will be sending forth to the full SURG for our, I think it's October 3rd for that meeting. So again, this is used using a weighting system. So you'll see on the next slides, they're ordered with the highest cumulative score down to the lowest. So the ones that are in blue, they show that multiple subcommittee members ranked them. So for example, this was the top ranking recommendation. You'll see that we had one person rank it as their top, another ranked it as their second, and another as their 4th. So then when you add up this column for the score, that gets you to the cumulative score of 110. And that was to continue to invest in standing up community health workers, peer recovery specialists, and certified prevention specialists throughout Nevada. The second highest cumulative score was to support a backbone agency that specializes in data collection. I won't read through all of this. This list is on the SURG website too, if anybody wants to download that in real time and go back and look. I did also want to note for this one specifically, during the last subcommittee meeting, I believe it was noted that the response subcommittee might be considering a similar recommendation. And my understanding is that they had their meeting earlier this week. They didn't come up with a recommendation that was this specific for data collection. It was something that's referenced in another strategy related to surveillance and data, but it's not this explicit. So I just wanted the subcommittee members to be aware of that. With a cumulative score of 80 was to make a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of naloxone kits. There was a suggestion in this next round of ranking to change the wording of naloxone kits to overdose reversal medication to encompass future drugs that may come out. So when we come back through these and do any potential workshopping of these recommendations, we can see if you all want to change that. Next, we had, this was the recommendation that came forth from the last subcommittee meeting that tries to encompass everything that the subcommittee members said was important to them for supporting prevention and intervention in K-12 schools. So that would be by investing in multi-tiered system of supports and providing a robust platform of services at schools to connect families to pro-social education, early intervention, counseling services, and other resources to help mitigate ACEs, and to provide appropriate prevention education and programming and invest in certified prevention specialists in schools, increase school-based mental health professionals through a multidisciplinary cross-department school-based behavioral health team. So quite a big recommendation, but tried to encompass what the subcommittee members said was important. Another one was to increase school-based qualified mental health professional workforce. Again, that was kind of wrapped into the one we just reviewed. This one was to establish a fund within DHHS to set aside funding for small grants to programs geared towards substance use prevention and education. And that was the last one that had a cumulative score. So that was the last one that had more than one subcommittee member ranking it as a priority. So I'll just quickly go over these. One subcommittee member ranked as their top choice to enhance prevention infrastructure through MTSS training. Again, that's kind of wrapped in the larger education recommendation. Another similar was to provide appropriate primary prevention education and programming. We had another one. Again, we had this presentation at the last subcommittee meeting modeled on Maryland's STOP Act, which authorizes certain emergency medical services providers to dispense naloxone to individuals. Another recommendation around expanding Medicaid billing opportunities. And then the last couple of recommendations. So one was to support training of key stakeholders statewide and the collective impact approach to affecting community change. Just talks about what the training should include. Another one was to address workforce development for youth and young adults through scholarships, work study opportunities, and training. We had another one on the Just Say No program, another on promoting telehealth for Matt, another one on building and strengthening comprehensive FAST in most teams statewide. And this is the last slide. So another one on supporting MTSS, and then establishing a bridge MAP program in emergency departments. So I'll turn it back to you, Chair. And if you want, I can change my view of the slides so I can edit them in real time based on subcommittee discussion.
Okay, let's go back to the recommendation on CHWs. That might be the first place where we can start from. That's the easiest one to start with.
Yes, let me go back and share my screen.
And while she's doing that, committee members, there was a question last time to bring up the presentation of CHW's community health workers in the interim HHS committee. I believe those have been posted or distributed to the members so that we don't have to repeat the representations. So we'll start off with this recommendation first. Are there any questions or discussion on this policy recommendation?
I can't see it. It's not loading on my screen. Am I the only one who can't see it? Emma, I know you started screen sharing.
I started sharing. Could I just maybe see a thumbs up if others can see it? Okay, it looks like Senator Doñate can, Jessica can. I can read it for you, Debbie, while it sounds like it's
Thank
loading.
you.
Okay,
Thank
so
you.
it's to continue to invest in standing up community health workers, peer recovery specialists, and certified prevention specialists throughout Nevada.
Thank you.
Okay, thank you so much. Do we have any questions or discussion on this proposal? We'll start with Senator Ganser.
Thank you very much. Jennifer was on the line earlier talking about the new behavioral health, I'll call it a center, but basically, trying to get the different groups, basically to create a strategic plan, have a center, which is virtual, not a building, to devise a strategic plan and really work on the behavioral health pipeline. And I think this fits very well. And I think we all know we have this immense shortage and incredible demand that just seems to be rising all the time. So I think this is an appropriate weighting.
Thank you so much, Senator Ganser. Ms. Johnson.
Thank you, Chair Doñate. I echo Senator Ganser's comment. I do think that this is an appropriate weighting. In reviewing the materials that were provided, for the CHWs. I just had a chance to look through the presentation, and it seems that, I don't know if there's an opportunity to make sort of such as to this. It seems very broad to me at this juncture. So one of the items that stood out to me as a current challenge of the CHWs was that the legislation that was enacted made CHW supervisors limited an NRS code to Medicaid enrolled physicians, physician assistants, and advanced practice registered nurses. So that presentation had some recommendations around more inclusive language for CHWs in other settings and with other funding mechanisms. And that would seem to me that this might be an opportunity, if we're going to add some specific recommendations about how we're going to invest in this, that be included. Thank you.
Thank you so much, Ms. Johnson. What quick response to that? So we submitted the bill as a bill draft through the interim HHS committee to make those changes. Obviously, the funding part is going to be the more critical part that we're going to have to get. So if that's a change that we want to include to make it such as with the responsibilities or the absorption of the reimbursement for, because that's going to cost more money, of course, if we're going to reimburse more under different providers, we can put that as well if we wanted to make a modification. Eric, please proceed.
Thank you, Chairman, and I really appreciate the comments of the previous committee members. I think they're spot on. I think this is a way to significantly grow our ability to respond to the needs of our students, especially. And I appreciate Ms. Johnson's remarks. If there are any sort of signs that we can point folks to in terms of low-hanging fruit, then I think it makes sense to do so. But I also like this being general from the perspective that we're really kind of shining a spotlight that any further policy discussions we really want, no matter what the subcommittee is, and I can imagine this coming up in schools, conversations with schools, conversations in prevention, conversations in treatment. We really want you guys, we think it's important to focus on utilizing community health workers, peer recovery specialists, and certified prevention specialists as a core part of that team. And there will be a variety of strategies that we can't even imagine and funding mechanisms for what that might look like. So back to Ms. Johnson's remarks, if we have an obvious way for folks to consider this, that is expanding the Medicaid eligibility requirements and the different venues in which community health workers could be reimbursed, also peer recovery specialists, also certified prevention specialists, then we should do so.
Okay. Ms. Johnson, do you have a recommendation of what you would like this to be changed to for a modification?
Sorry. Yeah, thank you, Chair. I just had a point of clarification, if that's all right. As I read the challenge listed here, it's that the barrier is that the CHW supervisors in NRS code are limited to Medicaid enrolled physicians, physician assistants, and advanced practice registered nurses for the reimbursement. That's how I interpret what's in here, so that CHWs in other settings with other staffing mechanisms, seems like the barrier may be around supervision. So I just wanted to offer that point of clarification.
Right, and that's the bill draft that has been submitted by the committee, which I think will be up for debate next session. But regardless, there is going to be an expansion of folks who will fall into this category, so perhaps it does feed into the reimbursement. So if we do want to make a modification, we could insert a comma at the end of this recommendation and including the expansion of reimbursement for these provider or for these folks, but or we could keep it as general. So unless if there's a motion to modify, I think I will keep it as regular. Emma.
Senator, I believe that, and I wasn't at the response subcommittee meeting, but I believe that one of their recommendations was it wasn't included in their top 5 to 7, but it was a separate one that was to support a bill that was already had a BDR. So I wonder if a possibility could be to leave this as it stands, as Eric had suggested, but then include under a separate category, support bill, and whatever that bill is that you're talking about, that would, seems like it would try to solve some of the problems that Jessica was talking about.
I think that's a fine approach. If there's anyone in disagreement, I would ask that you would probably make the comments now. Otherwise, we can make that addition, and I'll take a motion to make this one of the priority recommendations at this time.
Let's
Okay,
make that motion.
Chairman, sorry.
So we have a motion from Senator Ganser. Eric, did you have a comment?
No, I'll second that.
Thank you, sir. We have a second. All those in favor, please say aye or raise your hand.
Aye.
It looks like the motion passes unanimously. So we'll go ahead and list that as our first priority. Okay.
Great, thank you. I've added that to this so we can review it at the end, and then I'll get from you more information on at a later time about what the bill number, I guess it wouldn't have a bill number yet, but
Nope,
just what the
yeah.
language should be.
You could probably reference the work session document that was already discussed in the interim HHS committee. Okay,
Great.
let's go on and move to the second. There you go. Okay, so this was again part of the conversation that we had last time regarding whether or not another committee was going to facilitate this documentation. This is a proposal that we arrived at. So just giving the committee members one more chance to look at it before if there's any questions or discussion, I would appreciate it at this time.
I can't see it. I still can't see the screen.
Emma, can you proceed to read it out?
Sure. So it's to support a backbone agency that specializes in data collection, evaluation, analysis, and assessment, and provides consultation to entities across Nevada to help improve internal local data collection systems and create a comprehensive statewide data sharing system that includes all state dashboards and public data.
And my recollection on this was that we decided instead of contracting a company that we were going to build an infrastructure in the state, correct? That was the goal. Okay.
Yes, I believe that's why we changed it to backbone agency.
Gotcha. Okay. Ms. Nadler, did you have a question on this?
Yes, thank you so much. I read somewhere where Attorney General Ford gave a grant. I believe it's at the University in Reno. They're doing the data collection and all this right now that y'all are proposing, and it's been funded. At least $5 million went to it a few weeks ago. I forgot the name of it. It's in Reno. For those of you in Reno, you'll know it. They do the mapping, they do the recommendations, they do everything that this is proposing. They were just awarded a grant, and I don't know if this is the same thing y'all are talking about.
I think the goal of this policy proposal is to stand up an agency so that so that they can be self-sustaining in the future. And they can
Okay, so it's not an existing agency. You're talking about doing a new one.
Correct.
For
That's
that, correct? Okay.
in data collection so that future
Thank
grants can be applied for. Yeah.
Thank you.
Senator Ganser.
Thank you.
Senator Ganser, did you have?
Try that again. Hi, thank you again. So I'm not sure if it's an agency or if it's something within DHHS or exactly where it's going to exist, but I think data collection is extremely important.
Thank you so much. Any other comments or questions, Ms. Johnson?
Thank you, Chair Dunyate. I support or I echo Senator Ganser's comments. I do think I appreciate the wording on this because I do think there's an opportunity to think about an entity that may have either additional access or what I hear about this is some equity in supporting different groups around data collection and sort of that statewide comprehensive system. So thank you.
Great, thank you so much. And any other comment or question on this proposal? Seeing none, I'll go ahead and entertain a motion to consider this as our second recommendation. So is there a motion?
So moved.
A motion.
I got, I think the motion from Ms. Nadler. And do I have
Yes.
a second?
I'll second it.
again from Senator Ganser. All those in favor, please say aye or raise your hand.
Aye.
Any opposed? Any abstentions? Seeing none, I believe it's a unanimous approval for the second recommendation. All right, let's go to the third one. Ms. Emma, please proceed to read it when
Sure.
you're ready.
So this one was to make a recommendation to DHHS to utilize opioid settlement dollars to designate a baseline level of naloxone kits for the next 10 years in Nevada. It was to base this on the state naloxone saturation plan to create a stable, sustainable source of naloxone throughout the state. And then this was the one where there was a recommendation to change naloxone kits to overdose reversal medication.
Thank you so much. The first comment that I'll make on this one before I turn it over to the committee members for discussion is that I actually brought this up to Emma before this meeting started was, so in the notes, it says that we should consider removing naloxone kits and putting overdose reversal medication. I would like to hear feedback from the committee members if we wanted to insert other mechanisms as well. So the first thing that came to mind was, what about fentanyl strips, right? I think that's a conversation we have right now, but who knows what happens 5 years from now? There might be another trend or test strips that might have to be created that might not fit this definition. It might not be overdose reversal medications, but it could be medications that could limit the susceptibility or something along the secondary prevention lens. So I just wanted to ask if there were recommendations or if we wanted to change or make additions to it. That's the only comment that I have, but Senator Ganser and then Ms. Johnson.
Thank you, Chair. I think it makes sense to broaden the language because you're right. We don't really know what's going to happen in the next 10 years. I also do remember that the individual who presented from Maryland said they were having a hard time getting the naloxone. And I was somewhere the other day where the injection type naloxone is not always available, but the nasal is. And so I think using broad terms, because there may be other medications, there may be other like quick diagnoses, like you just said, the strips, something that would fit into this category. So right now it's around overdose reversal, but maybe it's identification and reversal, or medication identification and reversal of something like that.
Thank you so much, Senator Ganser. Ms. Johnson.
Thank you, Chair. I'm open to broadening this to overdose reversal medication. I would caution that perhaps if there are other prevention, overdose prevention medications that come out. I've attended several presentations from National Institute on Drug Abuse and FDA where there are medications sort of in the pipeline. I would imagine, however, that those might be for a different sort of part of the overdose prevention continuum that individuals might need. So I do agree that I think leaving this at overdose reversal medication opens the opportunity for products such as stimulant or methamphetamine overdose prevention and other types of overdose prevention reversal medications. But I would like to keep this at specifically the overdose reversal medication. Fentanyl test strips are an incredible harm reduction strategy, but they wouldn't necessarily revive someone who had experienced an overdose. They're more of a tool for individuals to utilize prior to engaging in substance use. That's my feedback and open to other comments. Thank you.
Thank you so much, Ms. Johnson. I do recognize that the last part of the recommendation references naloxone again. So I don't know if we want to make that removal or just leave it specifically to that, but just wanted to mention that in case if anyone caught that. Eric, please proceed.
Yeah, thank you, Chairman. This is for our previous conversation of taking perhaps harm reduction strategies and considering those separately, I think is an important context to remember, as well as that because we really are talking now about different types of prevention. And I think fentanyl test strips, they are preventing overdoses from contaminated uses of drugs, deaths from having poisons basically in those drugs that people are using. So from a systemic perspective, to your earlier comments, from a systemic perspective, a really important tool to use. And so I think, I don't know if we want to keep this in the top 5 or the top 6 of our recommendations, or to move it over to the parking lot for harm reduction, as we talked about earlier, that we might do.
I think for the sake of organization, we can actually table this and we can come back to it as we go through the other recommendations, and we can set this one aside right now for if we want to look at if we're in agreement that this might fit under harm reduction as part of the harm reduction recommendations, we can come back to it and we can continue moving on. Ms. Johnson, did you have a comment on that?
I did. At the previous subcommittee meeting, had asked for some clarification around how to identify this sort of harm reduction set aside, and I think and there wasn't clarification at that time. So I open to what those sort of additional recommendations might look like, but I have concern that we haven't sort of identified what those recommendations are from the broader list. And as committee members, you can imagine some of them are, in some instances, a secondary prevention strategy. Some of them are tertiary prevention strategies, depending on the population and where things are at. So I just wanted to add that. I didn't prioritize these recommendations with sort of harm reduction set aside in mind, because it seemed like some of them could be in multiple categories, depending on who the priority population was indicated. For example, in our bylaws, letter C lists out a variety of populations, one of them being people who use drugs, another one being young people. So there's a wide variety of who this might be a secondary intervention for versus a tertiary intervention. So I just wanted to add that. I know that this committee has been brought in to include harm reduction in prevention and harm reduction subcommittee. So I do think that's been at least personally a challenging part in creating these recommendations. Thank you.
Thank you so much. Ms. Adler, did you have a comment?
I do. I will agree with Jessica about, and as far as the wording, I agree, whoever said drug overdose prevention kits, or however you want to describe it. As far as the fentanyl test strips, I'm not sure if anybody's read a lot about it. They're not, there's some problems with them. As far as testing properly, the explanation on how to use it, kids have overdosed using the fentanyl test kits because they're not using them properly. So I do believe that should go into another group, not ours. I agree with Jessica.
Okay, so let's go ahead and table this one for now. And we'll come back to it at the end of our recommendations. I think that's probably the best choice or scenario right now. No. Okay. So let's look at the next set of recommendations. So this is part of our school-based ones that we discussed last time. So Emma, if you can go ahead and proceed with reading this one.
Sure. So this one is to support prevention and intervention in K-12 schools by investing in multi-tiered system of supports, or MTSS, and provide a robust platform of services at schools to connect families to pro-social education, early intervention, counseling services, and other resources to help mitigate ACEs, and to provide appropriate prevention education and programming, and invest in certified prevention specialists in schools, increase school-based mental health professionals through a multidisciplinary cross-department school-based behavioral health team.
Thank you so much. Okay, do we have any comments or questions? Senator Ganser?
Thank you, Chair. When I look at this recommendation, I think in some ways this should be the top of the list, because that's kind of the point of this, to be honest with you. And when I look at the ranking, you can see that everyone, the 5 members ranked at either second or third. So I really think, no matter what, the one that was tabled a moment ago, that we probably at least should move this to third instead of fourth. So I would bump this up. That, again, it seems like it should be at the top of the list, but we know we need data. We know we need some other things. So anyway, I strongly support this one. And when we pass these on to the Attorney General, I want him to know how important it is and that we're emphasizing this, not that it really is number 3 in priorities. It's like what we absolutely need and want to do, but we understand we have to pick up those other 2 pieces.
Thank you so much, Senator Ganser. Ms. Johnson.
Thank you, Chair. I am in favor of this recommendation. There is a wording suggestion that I'd like to recommend for the committee on the second part of this, where it says provide appropriate prevention education. I'd move to modify that to age appropriate and insert evidence-based prevention education and programming to this recommendation. The committee is in favor of that. Thank you.
Thank you so much. Does anyone have any questions specifically on that modification? If not, we'll continue with the general comments. I don't see any.
My hand is raised.
Debbie, do you have any questions? Yep. Do you have any questions on that modification?
Yes, I do. I too agree with Heidi that this should absolutely be a top priority. If we can move it to number 3, I would highly agree. And I agree with Jessica on changing the word. However, I would if we could somehow, instead of use evidence-based programs, because as we know, this epidemic is changing. It's changed dramatically from the past 2 years. So using old based programs are not going to work. So instead of evidence-based, if we could use a different word, but I highly recommend this one.
Thank you so much, Ms. Adler. Eric?
Yeah, thank you, Mr. Chairman. First of all, I think Senator Ganser's comments were spot on. This really is the nut of what we are trying to do, I think, with this committee. And so the fact that it's in the top 3, I think, is important. The first 2 priorities that outrank it are basically mechanisms for accomplishing this. So I like how she framed that. And then secondly, Ms. Nadler's comments are spot on as well, too. We heard earlier from the Prevention Coalition representatives who talked about the importance of utilizing innovative prevention strategies, because that's how innovative strategies eventually become evidence-based. And so having the freedom to utilize both of those sides of that coin, I think, are important to acknowledge.
Can I ask a clarification?
Yep.
So does this make sense? How I would provide age appropriate, innovative, or evidence-based? Or are you suggesting to take out evidence-based?
Well, I'm not going to try to speak for Ms. Johnson. I like that we're trying to focus on something robust versus just something that maybe we imagine will make a difference and like there it doesn't. So making sure we have robust evidence-based programming. So maybe it's innovative and or evidence-based.
Ms. Johnson?
Thank you so much. I appreciate the opportunity to include something around this and be adaptable to the changes, particularly in the overdose epidemic. I would recommend perhaps that this say something like based on best practices, so that it builds on the foundational evidence that is in the community that we do know works from a topic perspective, from a perhaps an implementation perspective, being able to adapt to that. But I think if we're, I don't know, trying to be nimble in some of those ways, then based on the best practices that we know work, would be my recommendation. To say provide age appropriate, based prevention, education, and programming that is based on best practice. Or something to that effect. We also, it looks like, still have some of our prevention professionals on the line, so I don't know if it would be appropriate or possible to have them be able to make a recommendation here, Chair Dunyate, but thank you.
Thank you so much. Ms. Ross, please proceed.
Thank you so much. I apologize. I just, there is actually a system already in place in Nevada for innovative programs to what in our field we call be put on the list. So there's a list of already pre-approved evidence-based programs, and multiple innovative practices have actually gone through this program where they are reviewed by a panel of experts, and then they may not yet be on the big national evidence-based practices lists. I'm thinking blueprints, I'm thinking NREP, those are the terms that we use in our field, but they have been proven to work here in Nevada, and there is actually a system. It's the Evidence-Based Practices Work Group. So if any innovative programs are interested in becoming to be put on that list, there is a system, and I'm happy to walk through, and that is actually run through the Department of Public and Behavioral Health. So if you're looking for a way to include innovative programs while still ensuring best practices, that is a potential solution to what I'm hearing might be a problem.
Thank you so much, Ms. Ross. Ms. Nadler.
Yes, I agree. We should add the word innovative to this. In addition to what Jessica said, I think we can include them all in this wording, the innovative and proven evidence-based, but I think we absolutely need the word innovative.
Thank you so much. Okay. One final question to the committee members. Is this recommendation broad enough to where essentially can the Nevada Department of Education carry out the studying and the delivery of modifying its curriculum is to be essentially what we're asking for, to be age appropriate, innovative, and evidence-based? Is that being hinted at in this recommendation, in this part of the recommendation, or do we need to modify it even further? I personally think it's fine, but I just wanted to.
I motion we pass it.
Eric, did you want to say something?
I'll second that.
Okay, we got a motion from Ms. Nadler and a second from Eric. Any questions or comments? Seeing none, all in favor, please say aye or raise your hand. Aye.
Aye.
Any abstentions or any nays? Don't see any, so the motion gets passed unanimously with the effort that we label it as a third one. Okay, let's move on to the next set of recommendations. This is to increase school-based health qualified mental health professionals workforce. Are there any comments or discussion on this proposal? Eric.
Yeah, Mr. Chairman, it feels like, correct me if I'm wrong, if we went back to the last one that we just passed, is that not included in this too?
It is.
That's what I thought. I'm not sure we need to amplify number 4.
Yep, we'll continue on to the next one then. Thank you for that good catch. Okay. Emma, can you please proceed to read this?
Sure. So this one is to establish a fund within the Department of Health and Human Services to set aside funding for small grants to programs geared towards substance use prevention and education. And then there's just a little bit more explanation about how, we might need to reword this. Grassroots movements in our state who have either suffered a loss or are in recovery, saying that they're the most knowledgeable and up to date on what is happening and what is working and what is not working.
Thank you so much. The main question I had for committee members is, we had a presentation earlier today in reviewing the content. Would it make sense, instead of establishing a fund through DHHS, to perhaps reroute the increased funding for the prevention coalitions to continue their grant programming? That might be, since they already have the structure and they already have the ability to do so, that might be the easier route versus creating something new. But I just wanted to throw that thought out there before any of the committee members have questions. So Ms. Nadler, I think you have a question. Go for it.
Yes, I do. I know this is something that Senator Gansert recommended, and I highly agree with it. Sometimes the DHHS is so overwhelmed by so many different things, and God bless them. I love all their work. We have a lot of parents. I'm not even asking the money for me, but I see so many people in recovery and so many people who've lost children who are going out to schools on their own and doing so many things and using their own out-of-pocket money in doing so. I personally used my money to put up a billboard. I personally used my money to put up lights. I lost a child. All of us have lost children or have suffered because of Purdue in the first place. And we are using our own money and trying to make a difference, and they're listening to us. We have parents listening to us. We have kids listening to us. This is outside the box. There has to be some kind of funds set aside. It's not a victim's compensation. All the money in the world won't bring our kids back. But for all of those in recovery and those struggling and those grieving, we are making a big difference. There needs to be a pot set aside where we don't have to go through the Department of Health and Human Services. They're overwhelmed. I asked for a billboard. I wasn't given one. Me personally, I'm not asking for me again. I'm saying all the grassroots movements here. We're making a difference.
Oh, you're on mute.
Dang it. Thank you so much for that comment. Senator Gansey, did you want to say anything before I let the other committee members speak? I know just on the recommendation, I'd like to hear your feedback since that was something that you recommended earlier. You're on mute.
Sorry about that. Did that again. Okay. I would agree. I brought it up and I appreciate Debbie bringing this originally, because the concept, having some small grants and some things to help and really supporting the grassroots movements, because the person-to-person contact, the family-to-family contact really makes a difference, because we have sort of all this big machinery and we've got counsel, we have all these things, but the personal stories are what can most affect other people sometimes. So I'm very supportive of this, and I appreciate the opportunity to have it on the list. Thank you.
Thank you so much, Senator Ganser. Eric, please proceed.
I will just say that I appreciate the switch to increase funding for prevention coalitions, because the way it was originally worded, I was concerned that it was setting up a separate funding mechanism from the system we're trying to, I think, support, which is the prevention coalitions, which are very aware because it's part of their mission to be aware of local needs on the ground. So I think this is an excellent change, and I fully support this.
Thank you so much, Jessica.
Thank you, Chair. I echo Eric's discussion. I support the change to the Prevention Coalition funding. I do also echo Ms. Rodriguez's earlier comment about the second half of this. I don't know if including, I don't know what grassroots are, I guess. And so I would imagine that if this is going to move forward, that either that section needs, the last two sentences need to be removed, or we need to sort of further clarify what is meant, or wordsmith those last two components. Thank you.
I think the personal comment would be, I think the grassroots movements part is already covered when we talked about the school-based programs. That's part of the innovative work and ideas. So I think that might be already covered, and I don't really know where the second part of that sentence would correlate to, but just I would be fine if we wanted to remove that second part, but subject to what committee members feel. Ms. Nadler.
Yes, grassroots movement, Jessica, are small movements that have been started by people who have suffered a tragic loss or those in recovery. They're small groups who've formed together to make larger groups to bring awareness, sometimes across the country, sometimes across the state. They're not funded. there's no grants. People rely on donations. A lot of times from the donations come from those who've lost somebody or those in recovery. So grassroots movements are very important in getting things started across the country. A lot of things have started as grassroots movement and have gained a lot of ground getting things done. I do not think grassroots movement should be removed whatsoever. I think it's part of what we're doing in this state.
Thank you so much. Debbie, Senator Gansert.
Thank you again, Chair. So I agree, grassroots needs to be in there somewhere, because when you just look at funding for prevention coalitions, that ends up being very in my mind, those are formal organizations versus kind of the micro loans or micro grants potentially that we could put together. So I'm not quite sure how to fit it in there. So small grants programs geared towards programs to set aside funding for small grants to programs and other grassroots movements or efforts geared towards substance. So maybe right there for small grants to programs and grassroots efforts geared toward, and then you can get rid of the last sentence maybe. Just a suggestion, thanks.
Yep, I think the difficulty that a lot of folks that apply for grants can equate to this is that sometimes it's hard to write grants if you don't have the background, the research background to curate the proposals that need grant funding. So I see the efforts for that. Ms. Johnson?
Thank you, Chair. I appreciate that opportunity. I'm not necessarily advocating for grassroots to be removed. I'm encouraging the committee to define further what is meant by that. I'm thinking about if I were to receive this, if this recommendation moved forward in the full surge, I wouldn't know if I were a coalition director what I was supposed to be funding under this particular recommendation. So I guess I'm asking that I heard sort of two different interpretations of that from some of the comments from my colleagues, our committee members, sorry. I heard that this was exclusively for people who've lost a loved one in some of the comments. And I also heard that this was more towards small grants or microloans, but not with a population in mind. So I'm just encouraging us, if we're going to move this forward, to try to specify like exactly what that means. Encourage us, I guess, to do that. Thank you.
Okay. Ms. Nadler. Sorry, I'm writing notes in the back.
That's okay. And Jessica, I can appreciate that. Perhaps if we write the definition of a grassroots movement, you can look it up in the thesaurus, the dictionary. Perhaps if we put grassroots movement, i.e. put exactly what a grassroots movement is in that definition, then people would further understand it. I think it's imperative that it's in there, but we can define specifically what grassroots movement. And Jessica, I appreciate what you say. I was just using an example of the grieving moms in the recovery. There's a lot of other people. There's students making grassroots movements themselves. I've had few students contact me, and they're trying to start something in their schools. So that would be something to be included. The students are forming a group, Students Against Drugs. So perhaps if we define grassroots movement and put that as part of this recommendation, would that help clarify it, Jessica?
Jessica, did you have a comment or response?
Yeah, I mean, perhaps I'm just encouraging the committee to maybe think a little bit more about is the word, you know, and maybe it's just me that's sort of stuck on how to operationalize this, but making sure that our recommendation is going forward towards who is intended to be impacted by this. Thank you.
Thank you so much. Before I turn it to Eric for further discussion, I just want to, I think we might have caught an error. So The funds that will be collected from this effort will be allocated to DHHS. So I would recommend perhaps, so it's right now we're debating between, well, I don't think it's really much of a debate anymore. The wording says establish a fund within DHHS to increase funding for prevention coalitions. I think that was what we're debating about. I would perhaps change that to require DHHS to allocate increased funding for the prevention coalitions. There you go. Because of money, and the reason for this change is because the funding itself will go through DHHS. So what we're recommending is that they increase the allocation that they already do for prevention coalitions so that we don't have to recreate the wheel of approvals. Okay, Eric.
Can we add the word grassroots and preventions coalitions? Because there's already coalitions established that are already getting grants. There's a lot of small grassroots who are getting nothing. Can we add the word grassroots in there?
No, so Debbie, the word grassroots is already in there. What we're saying is we're giving the fund, rather than creating new funds in DHHS, whereas it's already established with the prevention coalition presented earlier, we're saying that the funding that they get, which we're hoping is increased funding, that they can prioritize grassroots. The question is, what do we include as part of grassroots? I think that's the subject of discussion. Eric.
Thank you, Mr. Chairman. I am going to have to leave for another meeting that started at noon, and I'm already running late, but I wanted to add my comments to this. I like this proposal. I think the changes make it stronger. I also, as somebody who runs programs in rural Nevada, for us to have the wiggle room to see what works and what doesn't work, I like that this is general and that we're not defining grassroots efforts. I think that is how we test what works. We see what works, what doesn't work. In my imagination, I could see this being administered where DHHS might say, up to 5% of the funds that are allocated to the coalitions can be used for this purpose, to try out these different innovative strategies that might come forward, and that we would look and see what bubbles up and what works. We've used such an approach to great effect with the Resilient 8 Coalition throughout rural Nevada, and by doing so have really been able to bring some practices that we wouldn't have previously even, I think, landed on because we had a chance to try them out. So I like that we're not trying to be overly prescriptive on this. And I would move that go ahead. I'll wait with my motion.
No, thank you for those comments. I too have to leave, and I'm open to a motion with the language as we have it right now.
Sounds good. So we got a motion from Senator Ganser, and it looks like a second from Eric. So let's, all those in favor, please say aye.
Aye.
Aye. Any opposed and any abstentions? Seeing none, the motion is approved, and we have now our next recommendation. I believe, Emma, do we lose quorum, or are we?
So I think we'll still have, if you, Jessica, and Debbie stay on the line, I think we'll still have a quorum because that's 3 out of 5. And that was our last recommendation that had a cumulative score. So we can continue to go through these, or we can go circle back to this one, just so the subcommittee members know this is what has currently been voted on to put forth to the SURG. And I think we don't have to fill all 7 slots. It was just recommended to submit 5 to 7. So I think
thank you. Sorry.
Thank you, Senator.
Thank you, Senator.
So it's up to you, Chair, if you want to continue going through all of these to see if there's any more you want to add, or if you want to circle back for how to handle this one in particular.
Yes, I would like to come back to that, but before we decide on that, Ms. Johnson, we haven't really talked about harm reduction. So what are your feelings on the remaining recommendations?
Sorry, Chair, to clarify, this recommendation is part of the priority or the full list of the rest of them that were prioritized?
This is the final one that was prioritized cumulatively between all the committee members.
Correct. Sorry, I misunderstood your question. Can you rephrase it for me? I'm sorry.
Sure. So would you like to continue and move on to the other? Essentially what I'm asking is, are there any other between us three and including Ms. Nadler, in the ones that weren't prioritized high, are there any other proposals that you would like to include as part of the recommendation, the final priority recommendation, before we talk about harm reduction? That's pretty much what I was asking.
Oh, okay. I'd love the opportunity to just maybe look through Emma's list, if that's all right, before speaking.
Okay, just let me know when you're ready for me to go to the next slide.
Stop. Can I make a recommendation? Provide appropriate primary prevention of education and programming of K through 12. Is that a repeat of what we passed already?
That's correct. Yep. So that would,
Okay, fine.
that would be
That's
included.
fine.
Yep.
Okay, let me go back.
Next slide, please. That first one, I think, Jessica, that was part of your harm reduction recommendation. So we can come back to that one later.
I'm sorry, for the promote telehealth for Matt. I know this is harm reduction, but is this something that we already do, or we don't do that for medically assisted treatment? We don't do telehealth for that, or we do?
Emma, do you know if there's anyone in the phone line that can answer that question?
I am not sure. I think that's something that we could get a future speaker for. It looks like we have Dr. Kearns and Rhonda Fairchild with their hands raised.
Let's go with
Okay.
Ms. Kearns. Dr. Kearns, please proceed.
Yeah, I was just going to say that with COVID, the use of telehealth was something that was implemented, but I think that the recommendation is referencing the fact that we want to continue to use telehealth because it has been a proven effective method that was used during COVID.
Well, I think that's important. Because I know I've had a lot of phone calls from kids and they don't know where to go for help. I mean, is that something we're changing? Or are we keeping that? Or is that something we have to decide on? That telehealth for Matt?
I believe that's, if we want to pull that as one of the recommendations to be our final policy recommendation, that could be an option. We'll come back to that, since that,
okay,
that also falls into harm reduction. I'm looking at Jessica to give me the nod.
Okay.
Okay. Any more time on this slide before we go to the next one?
I'd like to come back to the fast and most teams one, but would appreciate the opportunity to read the next slide if that's all right.
Okay, we'll pull that one.
I think this first one was already a repeat of the one we
it's the same.
Yeah. And so then it's just establish a bridge map program in emergency departments.
And next slide, please. Is that it?
And that's it.
Okay, let's go to the yellow highlights, and we can.
I don't think I highlighted the Stop Act one. Was that one that you also said you wanted to go back to, Jessica? Okay.
Yep. So let's start with slide 33. And let's talk about the comprehensive, fast, and most teams statewide. Okay, any comments or suggestions on this proposal specifically?
Yeah, sorry, Chair, I have a comment.
Please proceed, Jessica.
Thank you. If appropriate, if our Prevention Coalition folks are still on the line, I can't recall from their presentation if they classified this as a secondary intervention program or tertiary prevention program. And that may be relevant to this committee deciding if, depending on how we choose to move forward with the different types of recommendations. Chair, would it be appropriate if Hannah or Jamie are available to comment on that?
Sure.
Thank you.
If anyone can raise their hands to respond. So I can recognize you. Ms. Ross?
Thank you, Chair Jamie Ross, for the record. And Hannah, if you have additional thoughts, I believe this can be both secondary and tertiary, depending upon the severity of, the folks receiving services. But I do believe most of this would be tertiary prevention. But Hannah, you are the expert when it comes to Most and Fast, as being the agency who's overseen this program since its literal inception over a decade ago. So Hannah, if you have any additional thoughts, please jump in.
Don't see anyone raising their hand, so we'll just continue forward. Okay. Dr. Kearns.
I'm so sorry, it took me a minute to find the button. I just wanted to add that the response subcommittee has a general recommendation they're bringing forward to say leverage existing programs of funding to develop, we're calling them outreach response providers and or personnel that can respond to suspected overdose and follow up for support, referral and services. And FAST and MOST do fall under that general outreach support or outreach response providers or personnel.
Terry, what about the promote telehealth for MAT? Does that fall under there too?
We don't have that general one. We do have something for MAT, but it's more looking at our correctional facilities.
Okay.
Thank you so much. Any comments from the committee members on that item itself? Ms. Johnson.
Chair Daniate, what are your thoughts then on recommendations that mirror other committees? Are they ones that we would also put forward to sort of show priority, or is your preference that we select something else?
I wonder, could we put it as a separate like support item?
So not as a policy recommendation, but just as a support item, saying that we support. I mean, realistically, I think, can you go back to the recommendations that we've already agreed on?
Yes.
The only thing that I see missing from this, right, we've talked about increased funding for grant programs. We've talked about reforming the education system. The last thing that's not on here is kind of the blend of reimbursement and expanding access to care. I think that part of that, there was a proposal, a different proposal on billing. We can make this just general and everything else can fall into that, which is the FAST and MOST program. And then the rest of it, and then we could just leave the rest of the recommendations for harm reduction. That might be an option. The generalized, right? Across the board. Can you go
ahead.
Can you go up to slide 32? I think it was on slide 32. Maybe reword. Nope. Slide 30. Try 30. Nope. Where was it?
Are you talking about the Medicaid one?
Yeah.
right here.
There you go.
That one.
So are you suggesting to write a potential fifth recommendation that kind of encapsulates some of these other ones? Like, should we just try to draft that right now and take a vote?
Yeah, that would be
Okay.
my recommendation.
Just so I'm clear, this would be a sixth one, or this is something that's going to take over something we already passed?
No, this would be our fifth one, actually. So the reason,
Okay, because we have, I got you. I'm sorry.
Yep.
I
The
understand.
reasoning I'm making this recommendation is because, for instance, this is a scenario that I see possible, and I think we could fix it if we have a policy recommendation to target it. So there's a discussion of considering detox as part of something that could be reimbursed by Medicaid as we're going through crisis stabilization and the setup of that. To support that infrastructure, we obviously have to allocate funds so that folks can get reimbursed for it. It doesn't fall into any of the recommendations that we've done so far, but if we curate something that can not just expand Medicaid reimbursement for specifically for at-risk youth, but just a generalized of the initiatives that we're doing, that itself improves access to care, which is prevention. So, I think that's probably the last missing puzzle piece that we have from what we've
No,
already.
and I agree, but can we take it a step further and do some kind of, I don't know how to word it, but free detoxing? There's a lot of kids being turned away. I had to detox my son at my house. How do we encompass it to give those who need detoxing, because they're being turned away,
Right.
a lot of them.
I think my recommendation wouldn't be to just isolate detox, but more so look at expanding anything that deals with this subject, which is why I was looking at it in general. Jessica, did you have a comment on this?
Thank you, Chair Duniate. I think I was looking through our the sections of the bylaws for this committee and trying to align my mind with sort of which ones it fell under. And I didn't have the full spreadsheet pulled up. My apologies. So I think I was trying to wrap my head around how to be helpful in this scenario. My apologies for not having more concrete information.
So, is there anything from this recommendation that you want to pull forward, Chair, into the one that we're creating?
Well, at-risk youth would be preventative, correct? I mean, I'm reading that. It said at-risk youth, that last one that you had up there. So it would kind of deal with both about the Medicaid.
Emma, it looks like Chair Duniate dropped off.
Oh, okay.
He had
I'm guessing he had an internet
Snafu.
It looks like he, I don't know if anybody on the AG's office is on the line. I think we can continue with the meeting, but we don't currently have a quorum, so we wouldn't be able to take any action.
Okay.
But if you, I know we're over time. We do need to get this slate of recommendations to the SURG. This is our last meeting before, so I think maybe we can give it a couple minutes to see if he's able. Oh, he's in the waiting room. Let me admit him. Okay, looks like he's back.
Apologies, got booted off. Okay. I was mentioning, Emma, can you go back to the blended Medicaid recommendation?
Yes.
Just so I can see it again.
Sorry, I already lost it again. There we go.
Honestly, we should just take this we can just take this recommendation and just cut out for involved in at-risk youth and just make it more generalized for and Medicaid billing opportunity.
Youth and adults? What if we say youth and adults, or youth and adults? That gives it a broader spectrum.
Jessica.
Thank you. Is the vision for this to still be for system involved and at-risk individuals, or is the amendment to this wording intended to be for like individuals who have Medicaid?
I would prefer the second option, make it more generalized for folks who have Medicaid. You can make the argument that that's already folks that experience the most social determinants of health. And that could, so maybe let's take out for a system involved in at risk, let's replace that with to expand access to care for youth and adults. Suffering, well, actually not suffering.
It could be anything. They could be predisposition. They could be already used. I mean, I think making it standard like that leaves it open. I mean, right? I mean, leaves it more generalized to use, or do we need to narrow it down?
I'm wondering where to add prevention in this. Essentially, what we want to do is we want to expand Medicaid opportunities to services that might align with prevention.
Okay.
There you go.
I think that looks good. My personal opinion.
Jessica?
Yeah, thank you. I'm in favor of moving this forward. I guess the nerd in me is looking through the bylaws to really think about which one it fits under. So I'm in favor of moving this forward as written. Thank you.
Sounds good. Do we have a motion to go ahead and approve this as the fifth and final one from this section?
A motion.
Thank you, Ms. Nadler. And do we have a second?
I'll second.
Thank you, Ms. Johnson. All those in favor, please say aye or raise your hand. Aye.
Aye.
Looks like it's unanimous. We have our fifth and final recommendation in general. Now we can move to the harm reduction ones. Okay. Let's go to slide.
Go to this one. This was the one that had the highest cumulative score that could potentially fall under harm reduction. And so I brought up the bullets that were discussed in the July meeting where we talked about harm reduction, and it stated that the prevention committee could include a for further review section. And if there's consensus among the entire SURG when it meets in October on harm reduction strategies, and we specifically said such as naloxone distribution, then it could be included as a complete recommendation in the report. So I wonder if we wanted, maybe I can start a separate slide that includes those kind of recommendations, and then they can be brought forth for consideration among the full SURG. Just a thought for how to handle these remaining ones, knowing that we are about 30 minutes over on time. And I'm wary of the three of you, because we have to make sure you can all stay on before so we can approve these last recommendations.
I can stay on, and I think this is a very important recommendation, whether it goes with prevention or not. I mean, obviously, this is very important. I mean, it's got to be addressed.
I would like to group this one along with the one on slide 31 and slide 33, the MAT one. Yep. perhaps combine all three of them. And I think that covers most, if not all, the harm reduction ones. Jessica, did you have any comments on that?
Yeah, thank you, Chair. Emma, can you, so would is the current proposal on the table then that we would add these as number 6 as harm reduction, or were they separate? Sorry, I think
I think it could be either. It's up to you all. So is it possible to combine all three of those into one and make it the 6th recommendation? Like, could be something like support, harm reduction through, and then I could just bullet those 3.
If we do that, will it take away people who vote? I mean, I guess I'm confused and I'm sorry. If we add that under the prevention, what we've done, will it take away possible votes for the other 5 that have to do with prevention, or no? I'm probably not making sense, and I'm sorry.
No, I understand what you're saying.
So how about this? Instead of making this a 6th recommendation, this will be the recommendation that we provide for harm reduction, considering that other committees might submit similar or their own recommendations, but from the prevention lens, this is what we're submitting. And it would be the 3 things that there you go.
I like that. I like that.
Ms. Johnson.
Thanks. If I can just make a comment, I do think the opportunity to sort of more fully and broadly consider harm reduction recommendations. I know that it's been within the other purview of this committee somewhat of a challenge. So I agree that this is a great opportunity at this juncture to move forward. And I'm hopeful that at the full SURG committee, there can be some additional discussion or opportunities to discuss harm reduction recommendations further as maybe a separate entity that would include folks from the response and the treatment and the prevention subcommittee.
Yep.
Thank you.
Thank you so much. Ms. Nadler, did you want to say something else? Or
If I understand Jessica correctly, you're saying to make it separate, Jessica, and then just present it as a whole and try to do it under harm reduction for all 3 of the committees?
Opportunity to respond, Chair. Thank you. So I am in support of moving this forward as it stands as a 6th recommendation from our committee. I would like to make the point here, and happy to make this at the October meeting, that given the task of such a broad purview under prevention with primary, secondary, tertiary, that inclusive of harm reduction strategies, that I think there's an opportunity for the full SURG in October to consider maybe some more detailed opportunities to come up with additional harm reduction recommendations. But for the sake of this meeting, I'm comfortable moving forward at this time. Thank you.
thank you so much. Sounds like we have a motion to approve. Ms. Johnson?
A motion to approve the recommendations, 6 recommendations as written.
Thank you so much. And Ms. Nadler, do we have a second?
I'm not so sure. I'm sorry. I almost want it to be its own so that we can include it in everything. I think it should be a recommendation for harm reduction. I think it should have its full entity of recognition as harm reduction. I just don't want it to take away from anything in the prevention. I mean, obviously, I agree it's much needed. Like I said, trust me, my son didn't have the help. He didn't have the detox. I think it's a very important aspect. I just think it should be an aspect on its own.
Gotcha. Thank you so much, Ms. Nadler. Jessica, do you have any final comments before I proceed forward?
Yeah, thank you, Chair. Debbie, I agree that I think it needs a separate, further in-depth discussion for consideration. I'm not seeing at this juncture. I was made aware that this committee is the Prevention and Harm Reduction Subcommittee, and so I don't see from the 6 at this time with moving out of this committee that it supersedes any of the other 6 recommendations. And I am of the opinion that at our October 3rd meeting, there's an opportunity to advocate for all 6 of these by the full SURG committee. Thank you.
Okay, I guess I must have missed a meeting where we added harm reduction to this committee. When was it added? When I wasn't present? Because it was always prevention, never prevention and harm reduction from the beginning.
Emma, can you please clarify how we arrived to this, please?
Yes, so in the March 9th SURG meeting, the full SURG meeting, when the subcommittees were created, Vice Chair Tolles, and these are in the minutes, she said that the prevention subcommittee will have a comprehensive view, including primary, secondary, and tertiary activities, plus harm reduction. Required activities include everything from leveraging and expanding efforts by state and local government agencies to reducing the use of substances and making recommendations to the pharmacy board, other professional licensing boards, and licensed practitioners. They will evaluate the effect of substance use disorders on the economy, study advocacy, and expand the implementation of programs. So when the subcommittee was created, it did say plus harm reduction. And I think, as Jessica alluded to in the October meeting, there will be further discussion for how to handle harm reduction in the subcommittees going forward.
Okay.
So, yeah.
Oh, all for it then. I totally did not see that part, and that's my fault, my mistake. And yes, I agree with Jessica. Added as number 6. I second her.
Thank you so much. Okay, now that we've arrived, we have a motion again from Ms. Johnson and a second from Ms. Nadler. All those in favor, please say aye or raise your hand.
Aye.
Any opposed? Any abstentions? With the motion carried, we'll have this as our 6th recommendation. Everyone unanimous. Great.
And then
Okay.
I'll just include that as well, the support. I'll reference the work session document.
Yes, ma'am. Thank you so
All
much.
right.
I think we are done. So let's go to our last and final agenda item, which is 6 public comments. So at this time, we'll open it up for folks to in the public to make their comments. Again, just know that we'll limit it to 3 minutes each. So Ms. Fairchild, please proceed.
Thank you, Chair. Rhonda Fairchild for the record. I wrote this one down so I wouldn't stutter. As a person in long-term recovery, a question I ask myself is what made that 11-year-old girl pick up drugs and alcohol? These are the underlying conditions that need to be focused on for prevention. Had I had the resources to treat those conditions, I may not have picked up. Number 2, I was just certified as a certified peer supervisor for the state of Nevada. It's new, so I don't know the Medicaid billing around that, but I'm officially a certified peer supervisor. And then number 3, if this is a harm reduction committee, I hope you research and learn more about safe injection sites. And then number 4, the bridge program in ERs, we've been doing that with Center for Behavioral Health or Behavioral Health Group for the past, 4 or 5 years. And the problems that we run into is it's not in hospital protocol, what we want them to do. So the nurses follow hospital protocol. They don't call us to come and help with people who are, unless we sit in the emergency room for 8 hours a day, and we can't pay somebody to do that. So it would require changes in hospital protocols. It would also require training on overdose protocols for nurses and doctors, because the stigma is freaking ridiculous between nurses and hospitals and people who overdose. And make sure that they have aftercare referrals. Thank you very much.
Thank you so much, Ms. Fairchild. Is there anyone else wishing to provide public comment at this time? I don't see any. So I'll go ahead and close public comment. Thank you so much to the committee members and to the folks that tuned in today. I know it was a long meeting, but we have some good recommendations, and hopefully we can continue these conversations at the full SURG meeting that's coming up in October. So thank you again to our committee staff and to the folks that attended, and we look forward to continuing these conversations. So meetings adjourned.
Thank you. Thank you so much.